you know, it's more of a not a holistic approach, but a um, if you do this, you'll fix yourself, you know, get through it and you'll be all right. So I've changed the talk a little bit. It was exercise is the panacea for overconsumption of carbohydrate. That's in here, but I've it's more global on the effects of exercise without weight loss on insulin sensitivity. All right, so one thing I wanted to go over was we get all really bent out of shape about hyperglycemia or high blood sugar. And if you look at here's the symptoms on the right of low blood sugar or hypoglycemia. You feel tired, sleepiness, irritability, increased hunger, blurry vision, sweating, dizziness, headache, and shakiness. And if you get your blood sugar too low, say below 30, I believe, you can go into a coma. So, you know, we get hyperglycemia is a long-term risk. It'll take at least 10 years for that to cause problems with glycosylation of tendons, the heart, all that stuff. But an immediate complication is hypoglycemia. And if this can happen even in the type 2 diabetic who has high blood glucose. If you'll see down there in the second statement, there's only 10 grams of circulating glucose in the diabetic with a glucose of 200 milligrams per deciliter. So that's 10 grams in the circulation. You use if you're pretty exercise trained, you can use a gram of glucose a minute. So there's only enough in the bloodstream for 10 minutes of exercise in a type 2 diabetic. Um, you know, they have carbohydrate in the liver, supposing you don't go on a low carbohydrate diet. You'll have carbohydrate in the liver and that gets released into the blood. But so in type 2 diabetics use more carbohydrate than non-diabetics. This is because their muscles lack oxidative capacity. They're not well trained. They actually burn more carbohydrate than normal glycemic individuals. So clearly combining a low carbohydrate diet with exercise could lead to hypoglycemia, acute and severe. So when you exercise a type 2 diabetic, you need to make sure they're taking in carbohydrate or they might go hypoglycemic. And this is counterintuitive. You know, why, if you start with high blood glucose, are you going to have low blood glucose? But again, there's only 10 grams of glucose in the blood. If you do a calculation with 200 milligrams per deciliter and 5 liters of blood or 3.5 liters of plasma, you'll get 10 grams of circulating glucose. Now you have glucose or glycogen in the muscle too, but again, if you're on a low carbohydrate diet, there's nothing, you're burning that up. You know, that's not really available because you've been burning that up, and you're not getting anything from the liver, so your blood glucose is going to decline. So anyway, that's the first main point, is that you have to watch for hypoglycemia in a type 2 diabetic. Yeah, so this is the take-home message. Exercise is a powerful hypoglycemic agent and is more powerful in the type 2 diabetic, likely because of reduced muscle oxidative capacity. A low carbohydrate diet in the short term is a hypoglycemic agent, skipping a meal, for example. So if you're going to exercise a type 2 diabetic, you probably want them to eat before they exercise, so they have glucose in the blood. And I'll go into this more, but exercise alone without restricting calories or carbohydrates is a very beneficial way to go for the type 2 diabetic. So exercise and carbohydrates taken together are friends of the type 2 diabetic. Exercise taken without carbohydrate, and as we will see, carbohydrates taken without exercise are foes to the type 2 diabetic. That is, it would seem that eating a high carbohydrate diet and not exercising might be detrimental to your health. Now we're talking, the ADA has guidelines of these are old guidelines of 60% carbohydrate diet. This is assuming you're in energy balance. The problem arises when the calories come up too high and you're in positive energy balance. And so you store more carbohydrate, the carbohydrate drips out into the blood from the liver, and you have type 2 diabetes. Um, so another thing that's interesting is a fast doesn't really lower your blood glucose too much in the short term. This is a study done in Ron Maughan's lab where they 24-hour fasted people, and these aren't high glucoses, but you see they still stay normal after a 24-hour fast. And I believe this is the homeostatic mechanism of the body always wanting to maintain blood glucose in the normal range. Um, so in a 24-hour fast will reduce your liver glycogen by 83%. So really you would think your blood glucose is going to go down dramatically because your liver glycogen is very low and you're not going to release much glucose into the blood from the liver. So, what we're really interested in is the rate of appearance of glucose into the blood from the liver and the rate of disappearance of glucose from the blood by muscle. Muscle insulin stimulated glucose disposal, that is after a meal, is 80% of all glucose disposal in skeletal muscle. So, the focus should be on skeletal muscle. A lot of people get hung up about the fat cell and all this stuff, but the focus should be on skeletal muscle and moving skeletal muscle. Yeah, the mechanism, I think the glucose fatty acid cycle is the mechanism by which the glucose maintains its normal range with a 24-hour fast and maintains homeostatic mechanisms. I'm going to go into a little bit some other stuff here with um, fasting blood glucoses and hemoglobin A1Cs, some stuff I found out. But here's what the way things go. Liver glycogenolysis, or the breakdown of liver glycogen, goes into the blood compartment, and the blood compartment is what we sample, and then it then goes into the muscle intracellular compartment through the interstitial space, etc. But a lot of the drugs that are out there now affect liver glycogenolysis. There's no real drug out there that's going to increase this value right here. So you take in more glucose exercise is the only drug there is, but there's no drug on the market that does that, as far as I know. As far as stimulates GLUT4 transporters to come to the membrane and dispose of glucose. Yeah, so it's a balance here of liver glycogenolysis, increases and decreases in the blood compartment, and muscle uptake of glucose. So we need to take all this into account. These are some studies that were done, pretty interesting studies done on glucose uptake by muscle from exercise. And this is disparity between blood glucose changes. With your doctor, you go to your doctor and you get your fasting glucose taken. Well, it may not mean that much if you're exercising. So Wang, this is one bout of exercise, changed fasting glucose 3.4%. But when they used the gold standard for insulin sensitivity, which is a euglycemic clamp, that improved insulin sensitivity by 12.9%. Pretty big, a fourfold disparity in the glucose changes by clamp and by looking at fasting glucose. Kerwin, 7 days of prolonged exercise. It was about an hour a day. They had people exercise for 7 days. Fasting glucose only changed 5.1%. Insulin stimulated glucose disposal increased by 45.1%. So again, this is a really big change in only 7 days of exercise for an hour a day. but fasting glucose only changed a little bit. Ferrari, this was from what's his first name? Dr. Goldberg's lab, Andy Goldberg. He was at the University of Maryland, and they basically had people exercise for a long time. I believe it was 6 months or 12 months, and they had 23% increase in glucose disposal from aerobic exercise and 13% for weight training. And the blood glucoses didn't change at all. You know, their fasting blood glucoses didn't change at all. So the major point, fasting blood glucose concentrations are not reflective of the body's ability to dispose of glucose. So I'm writing a paper right now, and the same sort of results I'm finding with hemoglobin A1C. Basically, they don't change much. Like fasting glucoses, even if you exercise your butt off, and your glucose disposal improves with the euglycemic clamp. And sort of under similar conditions, but you know, it's a better measure. Now, you don't want to go into a doctor's office and have to have you know, a 6-hour procedure to figure out whether you have diabetes, but there are other things we can do to you know, make sure that people are on the right track. So again, other techniques that measure dynamic nature of glucose kinetics are much better predictors of insulin action or tissue sensitivity to insulin. And these results are not anomalies. They're consistent in the literature. Again, why are fasting glucose is used in clinical practice? Surely we can do better. And you know, I think that what I'm trying to point out here is we don't have to scrap the whole thing. We need to practice best practices. So if you can know your patients exercising, you know, what I found is that it's an hour a day, and consistent hour a day exercise will normalize blood glucose from these studies that I've been researching. But if you can get them to do best practices like exercise all the time, then sometimes you don't need these clinical measures. You know, you know they're on the right track. So rather than having a euglycemic clamp, which is expensive and you know, time intensive, you don't have to have that. So there's other options too. You know, you got glucose tolerance tests are a possibility. They only take a couple hours. IV GTTs would be another option. So intravenous glucose tolerance test. They only take a couple hours as well. 40 minutes they've got them down to now. So exercise without weight loss is a proven improved insulin sensitivity isn't the best practice. I'm reiterating, and there's some other studies in here, but 7 days of exercise for 60 minutes increased glucose disposal by 45.1% and improved insulin sensitivity, obviously. 10 days of exercise for 60 minutes. And this is a pretty moderate intensity. You don't have, you can talk while you're exercising during this intensity. And there was quite a bit of increase in, during a hyperglycemic clamp, they saw a 56% increase in glucose disposal. I showed this before, but 1 hour of exercise training, a single bout at 60%, that's conversational pace, increased glucose disposal by 12.9%. And then this is on the opposite end of things, 6 days of detraining in runners decreased glucose disposal by 15%. And what they show is you need to exercise probably every other day to keep your, you know, it's a short-term effect, the effect of exercise every other day. So 3 days a week at least, to get the glucose transporter proteins to come to the surface of the cell and build up the glucose transporter proteins in the cell. Resistance exercise is an effective means to improve insulin sensitivity. Now, this is a power lifter, and there's some old data out there about power lifters, and they didn't have the greatest glucose tolerance. But, you know, I actually power lift, and I've added some rucking or walking with a backpack and a weighted backpack. And so, you know, you need to add something to the powerlifting probably, but other types of resistance exercise like bodybuilding would be good. many sets. A bodybuilder will do 15 or 20 sets per muscle group, and that'll improve glucose tolerance or insulin sensitivity. And then there's CrossFit exercise, and that's new now, but you don't have to do all the jumping up on boxes and down on boxes, but doing the fairly intense short-term stuff will also improve your glucose tolerance. John Kerwin, who was at the Cleveland Clinic and is now at the Pennington Biomedical Research Center, just published 2 articles using CrossFit, and it does improve insulin sensitivity as far as resistance exercise. Clearly, aerobic exercise is a great means of getting rid of glucose in the blood by way of the muscle. So that would be a good way to go. All right, exercise is the panacea for carbohydrate overconsumption. So carbohydrates get a bad rap. Rise in triglycerides if you have too much carbohydrate around, increase in fat mass, and causing insulin resistance. If you get too much glycogen in your muscle, the glucose can't go in. The muscle acts as a sink, and the glucose can't go in the muscle and be disposed of. So that is why you get insulin resistance with too much carbohydrate. Now, this is only the case if you're in positive carbohydrate balance. Now, this is, you got to count carbohydrates, and somehow we have to get a good measure of how many carbohydrates you're burning. But, we know that an hour a day of exercise will do this. We'll do a good job at getting you in negative carbohydrate balance. So they did a study in swimmers in their 20s. These guys are in good shape, but they depleted their muscle glycogen stores from swimming in a low carbohydrate diet. And they basically had to eat 500 grams of carbohydrate before they started to make lipid, de novo lipogenesis from the liver. So here's the storage space, about 500 grams. So it's going to vary on how much you exercise and how much you eat as far as carbohydrate. You eat more carbohydrate, it's going to be less than 500 grams. But the max is 500 grams, it looks like, where you deplete the stores and then you eat 500 grams of carbohydrate over a course of a few days, and then your triglycerides will start to rise. So again, it's a balance of exercise and carbohydrate intake. Carbohydrates aren't necessarily the bad guy, and for things like marathons and ultra events and things that are more than an hour, carbohydrates are essential to peak performance. So if you want, if you're the weekend athlete or whatever, and all right, I've talked about these studies before, but exercise in the short term can substantially increase insulin sensitivity, and these are the data. Even one bout of exercise will improve insulin sensitivity. This is sort of a complicated graph, but carbohydrates fuel exercise even at relatively low exercise intensities. When you start as a detrained person and you go out to start exercise, you're going to rely more on carbohydrate. And this is just intensity of the exercise. And the carbohydrate is fuel and the fat is fuel. Now, training will move this over to the right a little bit so that the crossover point's a little further down, but typically you're relying on a lot of carbohydrate, even in slow activities. As you get more fit, you rely on more fat, and that's possibly a good thing from the standpoint of diabetes. As I'll show, they think that carbohydrates are one way. High carbohydrate levels in the muscle are one way to cause insulin resistance. The other way is they think that it's lipids in the muscle. So the more lipid you burn as you get more trained, probably the better off you are with regard to insulin sensitivity. They really haven't pinpointed whether it's carbohydrate or lipids. There's evidence for both. It could be both of them, overconsumption of both. So this is just the way. I'm not going to get too much in detail here. It's pretty complicated, but insulin and exercise act through GLUT4 translocation. So there's calcium release, the AMP to ATP ratio, reactive oxygen species, and mechanical sort of transduction for exercise to cause the GLUT4 molecule to go to the surface of the cell and log glucose in, those purple molecules there in there. So, and insulin acts the same way. Insulin acts the same through a different pathway, but it causes GLUT4 translocation. So, and this is the way the Randall cycle. It shows a way that fatty acids could be causing insulin resistance. So you have fatty acids here released by the fat cell or in the muscle, actually, the intramuscular triglycerides, and they go with acetyl-CoA, go to acetyl-CoA, combine with oxaloacetate and form citrate. Citrate will feed back on phosphofructokinase, which is a glycolytic enzyme, and glucose can't come in the cell. So it feeds back, and then it sort of causes a backup here. And GLUT4 can't translocate glucose. So that's a way lipids could be causing insulin resistance. And then this is some cool data that shows that as long as you're turning over the lipid, you're turning it over by way of oxidation, consistent exercise, that you're going to have good insulin sensitivity. So we think that intramuscular triglyceride will cause insulin resistance, but if you turn it over, by way of exercise, and this SDH staining is succinase dehydrogenase, an oxidative enzyme, and this is the glucose disposal. So it's a 0.37. It's not a great relationship, but it's they think that the turnover is what's causing it. And this is mainly from Brett Goodpaster's group. He's down in Orlando, Florida now, but it's a matter of consistently doing exercise and oxidizing the fat, oxidizing the lipid, and you'll have a good insulin sensitivity. So the take-home message of this talk: hypoglycemia is a severe problem and can be life-threatening even to the type 2 diabetics in the short term. Changes in fasting glucose are not reflective of the body's ability to dispose of glucose. Exercise is an effective means of improving glucose disposal. Negative effects of carbohydrate consumption can be ameliorated with exercise or attenuated, stopped, whatever. And lipids could be implicated in impaired insulin sensitivity, and muscle oxidative capacity is correlated with glucose disposal. So, and there's me. I practice what I preach. But I'm adding, like I said, I'm adding rucking to the powerlifting. But I was having problems making 275 for about a year, and then I just started losing weight. I started getting more aerobically active, and I've lost 21 pounds. So that's probably going to help me, I think. Hopefully, that's what my doctor tells me. Any questions?